All right, guys, hello. Wanted to go ahead and put together just a quick lecture in the midst of all the craziness today. Wanted to deliver on my promise to get these up for you, so here they are. Okay, guys, after these two lectures, uh, this is the last of our material on concussion. Okay, so we're going to go over our last symptom profile. Okay, so that's essentially cognitive symptom profiles. Okay, and there are varying names for this: cognitive fatigue, cognitive and/or mood profiles, right? So you'll see these named differently throughout the literature. So ultimately, right, the one thing that we know is that cognitive symptoms are common following concussion, right? We know that from the SCAT-5, okay? And the post-concussion symptom scale within the SCAT-5 that we've used, right, with the 22 possible symptoms for a total severity of 130, of 0 to 132, right? There are cognitive groupings of symptoms inside of the PCSS, right? So the cognitive symptoms, though, that we often see with concussion are usually and are most often the ones that are actually that present the most frequently, and as we're going to see in a minute, have the most kind of far-reaching consequences. Let me turn down my brightness because my eyes are glowing. That's. So obviously cognitive symptoms that we know of that are inside of these SCAT-5, right? Headache typically accompanies all these symptoms, right? Light and noise sensitivity. Okay, a feeling of basically feeling slowed down. Okay, feeling fatigued or drowsy, feeling mentally foggy, difficulty concentrating, and difficulty remembering. So even though one thing that you guys are probably asking is why is it that headache and light and noise sensitivity are kind of also lumped in with cognitive symptoms? Well, it's generally because ultimately, right, the headache and noise sensitivity are essentially limiting sensory input, right, to the brain, which essentially results in delayed cognitive processing, right? And so these essentially these cognitive symptoms are very often and usually are always coupled with symptoms such as headache and photophobia and phonophobia. All right. What about modifiers? So if you guys remember from the SCAT-5, we spent time talking about modifiers. And those modifiers, if you remember, right, are previous history of concussion, right, and or head injury, could even have been a subdural bleed that they've had in the past, right? Are they, being treated for migraines or a headache disorder of some sort, right? So that's something that will obviously exacerbate and or also obviously prolong recovery from concussion, right? For documented learning disability, dyslexia, and then obviously ADHD, and or any other type of psychosocial concern, right? These things also have been known to obviously be contributing factors to protracted recoveries, those recoveries lasting longer than 14 days per the guidelines. And that, these often are things that can make concussion complex to manage, and often result in the need to, potentially even be seen by more than one specialist, such as a physician and even a neuropsychologist in some cases, due to difficulties that can present with neurocognitive testing in order to make, not only both diagnostic, but return to play decisions as well. So really interesting study done by Sean Eagle as an athletic trainer out of the University of Pittsburgh. And so ultimately, the question that they essentially asked is it possible, right, to predict a protracted recovery based on symptoms? And based on their research, they actually discovered that it's definitely possible to predict a protracted recovery based on symptoms. So again, utilizing the SCAT-5, which is a tool that we've been working with the most during our time of concussion, right? They essentially took patients and lumped them into two groups. The first group are those that had symptoms for less than a week, at the time of evaluation. So it's sustained a concussion 1 week or less than 1 week prior to being evaluated by a medical professional, right? And then those that had sustained their concussion greater than 1 week before being evaluated by a healthcare provider, right? So what they found here is that those that had sustained concussions and were evaluated less than 1 week prior to evaluation generally had higher symptom severity scores of headache and cognitive symptoms, and that the higher the headache score and the higher the cognitive symptoms scores reported on the SCAT-5, these were typically predictive of protracted recovery. And those that presented later, they found that those that presented with higher mood scores generally also, were more likely to have a protracted recovery. So it's really important, though, for us as athletic trainers to know the patients that we're working with, right? And that's one of the luxuries of being an athletic trainer, is that we see this often, particularly if we're working in the same practice setting, or in the traditional practice setting. We see the same patients every day, right? Every single day for a year, 2, 3, or 4, right? And so we get to know these people pretty well. One thing that's really important to know, though, is that a lot of times cognitive and mood symptoms don't always present in a dramatic fashion. Okay, there's actually some anecdotal evidence, and we're going to look at a really brief qualitative study that I did when I was working on my doctorate years ago, that kind of takes actually real life experiences from those with concussion and actually has them kind of talk about their symptoms, right? So we'll talk about that in a second. But ultimately, there's some evidence that people actually even begin to withdraw socially, right, and shut down after concussion, and lose interest in spending time with friends, loved ones, and just kind of become insular, so to speak. So other things that that we need to essentially pay attention to, particularly if it's someone that we're familiar with, is that sometimes there can be subtle personality changes, changes in friend groups, right? You may know, this patient or this person is someone that tends to spend a lot of time around one particular group of friends, right? However, that may not entirely be the case, and they may begin to essentially display kind of altered patterns of socialization and other environmental cues that might kind of lead you to, kind of follow a patient more closely. And there are times where maybe that patient didn't initially report their concussion, but because you've noticed actually changes in kind of some of their normal behavioral patterns, that could be a cue for you as a healthcare professional to just initiate a conversation with that individual and attempt to, potentially see, what could be going on, potentially concussion, right? So I wanted to spend a little bit of time, right, just kind of illustrating this point and just kind of letting you guys know how subtle this can be. So this was actually a real pilot study, very small pilot study that I did years and years ago. And we looked at essentially the lived symptom experiences of people that have had a history of concussion and that were currently actually recovering from concussion, right? And so we had 3 participants. And these are pseudonyms to protect their identity. We had Doug. He was a collegiate football player, 18 years old, with a previous history of 3 concussions. We had Joe, the 20-year-old volleyball and track and field athlete with a previous history of 3 concussions. And then we had Adam. Okay, Adam was a 21-year-old football player with a previous history of six diagnosed concussions. So here's the deal, and this is a little aside, but there's a rule that's out there, and people often say, well, how many concussions is too many? And really, there's not necessarily a fixed number. There is a rule out there known as the Quigly Rule that essentially says that once someone has had more than 3 concussions, they need to be done playing sports. Okay, that's called the Quigly Rule. But that really actually has a limited clinical relevance today, particularly as we see how varied concussion presentation can be and how varied recovery can be for some people, right? So kind of getting back to the demographics of our study, right? So mean age of 19.7 years, at the time of the study with an average of 4 concussions per athlete. So when we looked at the data after interviewing these participants, we noticed some themes, right? And that's how qualitative research works, right? As you pull data from these participants from interviews, right, and you develop themes. And so the themes that were developed in this study were flawed symptom conceptualization, essentially people lumping certain symptoms into the definition of concussion and creating a mutually exclusive definition of what was or was not a concussion based on the symptoms they were experiencing, right? And there were quotes from participants in this study that, well, I have all the symptoms, and I know it's a concussion because I have all the symptoms, right? When in reality, every single concussion is different, and every single concussion can present with different symptoms. Other themes that we're going to focus on were cognitive affective symptom impact and social relational deficits. So let's take a look at some quotes and just kind of some areas here. Okay, so cognitive affective symptom impact. Kind of some sub themes that we noted here was that we had people, essentially had kind of increased anxiety around their symptoms, and maybe even were a little bit paranoid when it came to experiencing symptoms following a blow to the head, following a concussion, right? And also people also noted feeling depressed. So let's take a look at some quotes from our participants. So this is Doug, right? Doug said, I would say that since I've had concussions or more concussions, I've kind of been on edge about a lot of things. And he says, just because I always think, well, do I have one? I always think that. Now, just because I'm so on edge about it, I'm just like, do I have one? And then I start thinking, and then I actually overwhelm myself into that, right? Thinking about, the likelihood of a possible concussion, even after playing football, even after not potentially even sustaining a concussion after, contact. And he's, here talking about maybe other, players or other teammates. He says if they've had a concussion, they're always going to, have it in the back of their mind, that the fear of getting one, right? And then he just, obviously expressed and noted that for him, someone who's experienced three concussions previously, that there was definitely fear, a level of fear associated with the diagnosis for him. Okay, so this is Joe. Right. As we can see, Joe also obviously noted kind of some increased anxiety, right? And so she, kind of is talking about the time when, at the time of injury, where maybe she wasn't necessarily displaying symptoms at first, but every time she felt something, she would turn to the athletic trainer behind the bench and let them know, hey, I felt this, I felt that, right? And she would just say, just turn and let the athletic trainer know every single time that she felt, a possible symptom. And so Joe, in this example, expressed feeling a lot more emotional and nervous, like we've seen in the SCAT-5, right? And she also, expressed feeling nervous about, developing symptoms with activities of daily living, things like walking to class, right? And just, expressed a lot of apprehension about the ability to live a normal life, right? And then also obviously noted some depression as well, right? Excuse me. She noted obviously becoming depressed more easily, but then not being able to come out of those depressive symptoms and or staying depressed for longer periods of time, right? Okay, so social relational deficits, right? People, here essentially decreased or, kind of described decreased social thresholds and this sense of voluntary isolation. So this is kind of some quotes from all three here. Doug said, so during a concussion, I'm buried in myself. I don't really converse with anybody. And then Joe says, yes, it does affect me. For one, I'm very irritable, and I can tell because I have a 2-year-old. So I can just kind of tell the difference of how fast she can irritate me rather than like how she can normally irritate me. So obviously, some decreased, kind of a decreased level of patience there with her daughter, right? And then Adam said, and for him, not really, any differences in wanting to socialize. He still wants to kind of go out and do things to socialize, but maybe just not as lengthy, right? And so generally speaking, those are typically governed by the onset of symptoms due to, increased social exposure, visual motion sensitivity, noise, those types of things. Okay. All right. So what do we do for these people? these people that are displaying, cognitive symptom profiles, right? So active treatment has been shown to be somewhat useful and helpful, right, within the cognitive symptom profile, simply because it gets people up and moving, and kind of helps address symptoms of depression, and lowered self-esteem, right? So it's really important though to remember that the guidelines actually tell us that all the symptom all of the activity that we essentially recommend for our patients should be sub-symptom. Remember, there is an initial rest period of 24 to 48 hours, and after that period of time, the patient can then return to sub-symptom threshold activity while still symptomatic, right? So activity levels, right, can be adjusted gradually, like light walking and stationary biking with low resistance, right? As symptoms continue to improve. And as we talked about, we can actually kind of correlate symptom exacerbation with heart rate using something like the Buffalo Concussion Treadmill Test, right, which is a graded exercise test that allows us to establish essentially an aerobic threshold for patients of what would be safe as far as activity, right? And it's really important to remember that before starting any formal return to play protocol with any patient, they need to be symptom-free. Okay, so we should not start return to play with a patient until they are free of symptoms for 24 hours or more. Okay, what about other things that we do for cognitive profiles, right? So one thing that's been recommended, obviously, is cognitive behavioral therapy. So working with a psychologist or counselor, right? When I was at TRIA, our concussion clinic had a relationship with a pain psychologist who saw many of our patients for counseling, particularly for those that had continued, either cognitive symptoms and or continued headache after concussion, right? Obviously, for all of our patients with concussion, appropriate diet and hydration is extremely important, right? Sleep hygiene as well. There are times where patients may not respond to, general management strategies that are non-pharmacological, like, good diet, and potentially psychotherapy, right? And so we may have to use medications from time to time as prescribed by a physician. Not uncommon to utilize at times anti-anxiety medications or antidepressants, such as Wellbutrin, and or other medications that may be helpful, right? And we've also talked about with other symptom profiles, particularly migraine profiles, utilizing medications like gabapentin and or amitriptyline as well. There is a really interesting method for cognitive profiles that has started to surface in the literature within the past couple of years, and that's known as exposure recovery. So what that is when you essentially take a patient into an environment that's going to exacerbate their symptoms, and you let them develop symptoms, and you expose them to the environment for a very short period of time, and then you remove them from the environment and let them recover. So while this is definitely not something that's received widespread recommendation in the literature, this is definitely something that has a foundation in cognitive behavioral therapy and helping people with things like overcoming phobias and those types of things. So just a quick presentation here about cognitive profiles. That is all the symptom profiles that we're going to cover for concussion. And like I said, this is we've got one more lecture, and then that is all the material that we will present for concussion as a part of the class. Thanks.